Sathyabama Institute of Science and Technology.
Hello all, this is Dr. Priya Kumari from Sathyabama College of Physiotherapy. Today I am going to talk about the motor examination. This is in continuation with the neurological examination videos which I have taken before. I will be covering about the introduction of motor examination, what is tone, reflex, muscle performance, strength and power, voluntary movement patterns, posture control, balance and coordination. Now motor assessment, first thing we need to check is the tone. What is the tone of the muscle? A tone is the resistance of the muscle to passive movement or passive elongation or a stretch. If the tone increases, it might lead to hypertonicity. If the tone is reduced, it will be flaccid or it will be hypotonicity. Hypertonicity can be further of two types, spasticity and rigidity. Hypotonicity is flaccidity. Then type of tonal abnormalities we may generate either in the upper motor neuron lesion or lower motor neuron lesion. Now how do we check the tone of the muscle? For that, most commonly to check the increased tone or spasticity of the muscle, we use a modified Ashworth scale. This scale 0, there is no increase in the tone, 1 slight increase in tone giving a catch when slight increase in muscle tone manifested by the limb was moved in flexion or extension. 1 place is slight increase in muscle tone manifested by a catch followed by minimal resistance throughout. 2 is more marked increase in tone but more marked increase in muscle tone through most limb movement which can be easily flexed. 3 is considerable increase in tone, passive movements become difficult. 4th, limb will remain rigid in flexion and extension. Next thing in motor assessment is reflex. Now a reflex is an involuntary or nearly instantaneous movement in response to a stimulus. It is an automatic response to a stimulus that does not require any conscious thought or as it occurs through a reflex arc. Now what type of reflexes we will be checking is the superficial reflex, deep reflex, and then we have pathological or primitive reflexes. Now as I told before, reflex occurs through the reflex arc, and reflex arc consists of, you will have a receptor and then we have a efferent receptors which will go through the afferent neuron, there is an interneuron, and through the efferent neurons the response will occur. Now reflex grading. The National Institute of Neurological Disorder and Stroke, NIND, according to them the muscle stretch reflex scale is frequently used and empirically supported. So what is that scale? 0 means reflex will be absent, 1 reflex is small, less than normal, 2 is reflex in the lower half of the normal range, 3 reflex is in the upper half of the normal range, 4th reflex is more exaggerated reflex will be there. Now what is the procedure for testing the reflex? Again the muscle group to be tested must be in a neutral position. The tendon attached to the muscles which is to be tested must be identified clearly and it should be exposed. Place the extremity is in a position that allows the tendon to be easily struck with the reflex hammer. To easily locate the tendon, ask the patient to contract the muscles to which it is being attached, and then tendon is being striked with a single brisk stroke. There should not be any pain. The classification of reflexes based on the receptor site, we have superficial, deep, visceral and pathological or primitive reflexes. Now what are the superficial reflexes? Skin reflexes which are elicited by stroking the skin. They are interscapular reflex, upper and lower abdominal reflex, gluteal reflex, anal reflex, cremasteric reflex, plantar reflex. Then mucous membrane reflexes include corneal reflex, gag reflex, uvular reflex and sneeze reflex. Now these are the main 6 commonly tested muscle stretch reflexes. They are your biceps, triceps, brachioradialis, knee, ankle and jaw jerk. These are the demonstrations of the biceps jerk. You can see how the finger is being placed and it is tapped to generate the reflex. This shows the demonstration of the ankle jerk. Here you can see the knee jerk, how using the knee hammer it is being tapped on the patellar tendon and it elicits the knee jerk. Now what are pathological reflexes? Pathological or primitive reflexes are the reflexes which are present by birth but it diminishes as the child grows or with age it has to vanish. But some neurological disorders, these reflexes remains and then it becomes a pathological. These primitive reflexes are pathological if it is found in adults and outside of the realm of what is considered to be normal. Pathological reflexes like Babinski, rooting grasps are reversions to primitive response, and it reflects the loss of cortical inhibition. Now strength. How do we check the strength? Manual muscle testing we use. The myotomes can be used here at the myotome level. The most commonly accepted method of evaluating the muscle strength is Oxford scale. Here it is a 5.5 grade scale, where 1 is flicker of movement, 2 is through full range activity against with gravity counterbalance, that is gravity eliminated plane, through full range against gravity, 4 is full range against some resistance, and 5th is through full range actively against strong resistance. So for this, to check the strength, we will be using the manual muscle test. Now voluntary control grading, especially for the neuro patients, they develop synergy patterns and their level of recovery is being tested using the voluntary control grading suggested by Brunnstorm. According to this, first stage, muscles are flaccid on the involved side. Second stage, the patient evidences minimal spasticity and little or no active finger flexion is possible. 3. The patient is able to hold on to handle placed in the hand but unable to release through voluntary finger extension. Reflex extension may be possible. 4th stage, the patient is able to release by lateral thumb movement with minimal finger extension or through normal functional synergy. 5th stage, voluntary masked extension of digits is possible and the patient is able to control cylindrical and spherical grasp with limited functional use. In the 6th stage, the patient demonstrates voluntary extension of fingers, lateral, palmar and 3-point prehension, and individual finger movements are possible. So this is for hand. Similarly, it has been given for upper limb and lower limb. Now range of motion. We can document the range of motion of both the sides if it can be evaluated in a tabular form. We have to note down the active range of motion, passive range of motion, both the right side and the left side of the body. Then we need to check if the tightness of the muscle is present or not, if any associated reactions are present, contractures or deformity, and then postural assessment is done. In the resting stage as well as in the by changing the positions also, the posture is being evaluated. Thank you.